everyone. I hope that you can hear me well. I am testing out an app on the computer, the Game Bar app, to see if this can be a way to record our lectures both for audio and visual on the presentation for our lectures to load in Canvas. So I am actually going to bring this up and turn that into a slideshow for us. So today we're going over the treatment of depressive disorders. But one thing I do want to mention as we're going through the treatment options that there is, and understanding, why would you choose this particular medication, and what is this going to do for the patient, what benefits or risk, etc. from this medication is, I know that this is a primary kind of preliminary course to your specialty for psych, and a lot of you guys may have also not, especially those who've not had family practice yet, learned exactly, how do we have those conclusions? How do we get to that conclusion of what is depression and how is it diagnosed, and how do we differentiate depression, unipolar depression versus bipolar? How do we know whether this is more dysthymia or generalized anxiety, etc.? And so with each lecture, I plan to actually take a little bit of time in the beginning of the lecture, kind of go through the what is depression, what are the criteria for diagnoses, the symptoms that you may or may not see with these patients. So then maybe you can form an idea, okay, now I can understand these are the symptoms the patient reports. They're obviously depressed. So what medication am I going to best choose to treat the patient? Just to, in summary, really to give you a little bit more etiology behind the diagnoses, what maybe causes it. And also that way you can understand, okay, that makes sense now. For example, if we have been reviewing in week 1 the neurotransmitters. And so if we understand, hey, our serotonin, when it's a little bit lower, that can cause us to feel more depressed. So then I might choose something that's going to hit that serotonin, inhibit the reuptake so that I can hold it in my body longer and actually feel better. And so things like that, just to kind of help you through the process. So to get started, the first thing is, what is major depression? Okay. So if you were to see that diagnosis, maybe if you've been working with fellow maybe other psychiatrists or other psychiatric nurse practitioners, clinicians out in the field, how do we diagnose major depression? You might see a major depressive disorder, and then there's usually, and you'll learn more along the program of knowing whether it's a reoccurrent single episode, and also being able to level out what the severity is. Is this a mild type of depression, moderate, severe, and so on. And even when depression can be very, very severe, you can have it severe enough that you do have psychotic symptoms. So they may actually be able to hear voices or hallucinate. And so that is something that we target. Does not necessarily mean that they're schizophrenic. Okay, it just means that the depression is severe enough. If you think about what it may be doing to the brain, it's causing those things to happen. So if we look at the criteria by the DSM-5, okay, they outline that major depression, the individual must experience 5 or more of the following symptoms that are on the PowerPoint slide during a 2-week period. So that's one thing. It has to run for at least a 2-week period. It's not that I've just been sad or depressed for one day. Okay, has to have been at least a 2-week period, and they've had to have 5 of the 7 that we're going to read out, which is now 8 with a DSM-5. I'm used to DSM-4, and they have to either be a depressed mood or loss of interest or pleasure. That has to be one of those. So, depressed mood, what do you kind of contribute to describe that as? Maybe the patient's having tearful episodes, they feel more down and sad, and they've got to have a loss of interest and pleasure. And a lot of times you're going to see both, guys. You're going to see someone who doesn't feel like going out and doing things. They really don't enjoy things like they used to before when they're depressed. So they've got to have a depressed mood most of the day, nearly every day, diminished interest or pleasure in all or almost all activities. Okay, significant weight loss or weight gain. Some of us are, when we're stressed, we're feeling down, that's the last thing we want to do is eat. We lose our appetite, I don't feel like eating, maybe nausea, so we might lose weight. There are also several people who will stress eat, and it's, I'm going to go and pick up a Ben & Jerry's thing of ice cream, and I'm just going to bury my stress and my feelings in cookies and ice cream and pizza and etc. And so a lot of times you're going to see weight gain. And also with patients that I'm used to with experience is binging kind of seems a problem. And it's that comfort. It's finding that comfort food sometimes for those. And so you can see either or on a spectrum. People may have severe loss. They may have been gaining. a slowing down of the thought, reduction of physical movement. This could be, just maybe like I can't focus, I can't concentrate as well. It's almost like I'm in slow reaction motion. I don't really want to get out. I can't think as quick on my feet. It's hard for me to roll out of bed. I really have to push myself. And then that kind of goes along really somewhat of the next one, fatigue, loss of energy. So I guess I would say 4 is actually having the behaviors of actually slowing down and reducing your movement and getting out. And then number 5 would be, it's feeling tired. I can sleep all night long. I sleep 8 hours and I still yet do not feel like I have the energy. Feelings of worthlessness, excessive or inappropriate guilt. And sometimes when you're talking to patients, they'll end up revealing to you just feeling guilty over things. I'm not around my kids enough, or I'm not able to take care of my parents, or just financially like, oh, I should be doing more, and I feel so bad, but I feel guilty for taking naps. Diminished ability to think or concentrate, I kind of already touched on with number 4, and a little bit it's just maybe in their everyday work, just not being able to maybe make even indecisiveness, not being able to make decisions with as assertive as they were before. What is a little bit different in the criteria in the DSM-5 versus the 4 is sleep. Sleep was one of those in the DSM-4 that was included. And it's, maybe you're sleeping too much or not sleeping enough. I guess right now what they're doing is they're putting that kind of with the slowing down of the physical movement and the fatigue, loss of energy. But sleep was a huge thing that and I'll have a mnemonic here in just a minute, that is always something you want to still assess is what is their sleep? How are they having trouble sleeping? Is it trouble falling asleep, staying asleep? Are they sleeping 16 hours a day? Like a patient of mine recently had actually told me they were doing. And then lastly, but not least, is, are there any recurrent thoughts of death? Suicidal ideations, has there been a plan? Have they actually had an attempt in the past or planning, something now? Or is there intentions? Sometimes people will say that, oh yeah, I've had suicidal thoughts, but when you talk to them, it's, they don't want to live like this. They want to feel this way, but they've never had a plan. They have no intent, is what a lot of times I'll document. No intent. They don't want to die. They don't want to do it themselves. They don't have any plans, but they just, some days it would be just easier, they'll say, or, I just can't continue to keep feeling like this. So those are criteria that help us to make that diagnosis for depression. So this was that little mnemonic. And I always kind of liked this. And just for those who are my visual learners, I know through school I'm a little bit of both audio and visual, and I'm definitely, most of all, when I posting the VARC assessment this week, I'm a doing. If I can do it, I can learn the best from that. And so, but this is just to kind of help if you do fall in that more visual category. So depression assessment, SIGI CAPS. And I have actually, and early on in practice when I first started, write this on a little paper, and just to make sure that I touched on all the points of diagnoses for depression and rule out even for children and adults. It was a very, very useful tool. Checking on sleep, again, it covers the interest. Also sexual activity. I think sometimes it's almost like we shy away from asking that question, but get clients to open up, be honest, because maybe there's more going on in that they haven't had a relationship, they haven't had sex with their partner in 10 years. And being able to ask those questions really puts another perspective of really what's going on. And when we're choosing the right medications, that's something we don't want to damper, but let alone depression itself can also cause a decrease in wanting sex. There's the guilty feelings with the GE for there. So you got SIG-E, energy decreased, and then CAPS, concentration, appetite, either up or down, psychomotor function, usually down, and then again the suicidal ideations. So specifiers for depressive disorders, there is anxious distress. You can have more of an anxious type symptoms, more worry stemming from the depression. And a lot of times, well, how do I know what is what? Ask them which one usually comes first. Are you usually a worrier when you're feeling good? Well, no. Or, oh, I worry all the time, even if I'm not sad. What is it stemming for more? So that'll help you rule out what your primary diagnosis is. Excuse me, tongue-tied. Maybe there's mixed features. Maybe, you'll learn about that more when we cover mood disorders, but maybe they're having a little of both all in the same period. A little bit of anxiety, a little bit of anger, irritability, down, depressed, just kind of a mixed of symptoms. There's melancholy, where maybe they are just very, very low, very, I guess I hate to give an example, but if we look at a Disney example, Eeyore, kind of more always down in the dumps, which he fits more under dysthymia, we'll talk about here in just a moment, but maybe more sad, more calm, no energy, things aren't great. And then there is what psychosis I mentioned earlier, peripartum and postpartum, so during and after pregnancy. And then seasonal patterns for those who suffer with the winter seasons, especially with there not being as much sunlight, obviously not getting that good vitamin D that we need, and the time changing, with time it getting dark earlier, and just reading different posts in the forums, and for those who are living in different states and parts of Alaska that have dark more often for several months at a time, I almost couldn't imagine. Living in the South, it's very, very common my way to see seasonal affective disorder is what we call it, for when they are depressed during those winter and darker cold months. So another thing that's not necessarily going to meet for major depression would be dysthymia. And this is kind of where I was saying Eeyore. The depressed mood for at least most of the day, for more days than not, are indicated by subjective accounts. In other words, you've had a depressed mood most of the time you're depressed. You don't really remember being happy. And that's a lot of times something what I'll ask my clients too, if I'm trying to decipher out, what is this? Are we constantly always this kind of negative Nancy, kind of more things are always down, never really remembered being happy? Or have we had really happy times in our life? It's just these really severe episodes of depression, that, again, remembering at least 2 weeks, that come in. Then that helps me decipher, okay, this is major depression, and this is dysthymia. They've never really been happy. So to actually diagnose dysthymia, at least 2 years of being depressed most of the time, maybe a poor appetite or overeating, same very, very similar symptoms. Okay, the insomnia or hypersomnia, energy, fatigue, self-esteem, again, hopelessness. It's just that's gonna help you to differentiate. Is that just not really remembering to be happy, and nothing's ever really just been exciting, and the depression's really never been gone 100%. I did put a note in there, it's child and adolescents, and you'll see that when we get into child and adolescent lecture, that kids a lot of times will display their depression through anger, through irritability, outbursts, more behavioral disturbances through their depression. So for a child and adolescent to be diagnosed, mood has to be, or can be, irritable, and at least has to last 1 year. All right, some biological factors, like what in the world is causing the depression? Why are people suffering through this and feeling sad? Why are these suicidal thoughts coming into play? There are 3 main neurotransmitters in the brain that are involved. So we've got dopamine, norepinephrine, and serotonin. And they're all 3 implicated in the path of, kind of puts this of why these mood disorders occur. So the dopamine is that, as you guys should be reviewing from week 1, is that kind of that pleasure chemical. It's also our concentration, our enjoyment chemical. That norepinephrine is that alertness and energy. If you think about, you remember norepinephrine, epinephrine, your fight and flight chemicals, fight or flight chemicals, and so that kicks in if we get scared and increases that heart rate. Well, it also is stimulating to the brain, helps us to be more alert and be more energetic and feel better. And then the serotonin, of course, is that other neurotransmitter or chemical that people may want to call it, that if we don't have enough, maybe we're passing it too quickly. One thing I would definitely like in the future is to study more on the relation with irritable bowel and bowel issues and the relation to depression, because maybe there's actually statistical research that says 80 to 90% of our serotonin is actually produced in our gut and not in the brain, like we a lot of times misthink that serotonin is just in the brain, but a lot of it's actually produced in your gut. And so sometimes people who deal with different biological issues or have had surgeries and gastric bypasses, etc., they have dealt with more depression, not having enough serotonin. So certain antidepressants also target certain amines. So for example, what that's saying is, SNRI, so serotonin norepinephrine reuptake inhibitor, and we're going to get to that in just a moment, but Effexor would be one, an SSRI, a selective serotonin reuptake inhibitor, example like Prozac, and then you've got NDRIs, Wellbutrin would be your example, a norepinephrine dopamine reuptake inhibitor. And what I'm saying is reuptake inhibitor is prohibiting it it's almost like from it taking it into the synapse too quickly and passing it on, and you're not really getting to use that and synthesize it in your body as you should. So some things that we can do. Obviously, mainly in this course, we're focusing on the pharmacotherapy type, right? That type of treatment. In your other course, it's going along, you're learning more of the therapy things. And yes, the answer is, by the books will always tell you the combination of therapy and medications together have more efficacy on as far as treatment and achieving stabilization. But just for this class specifically, we are going to focus more on the pharmaceutical type information you need to know. So one thing I tell my patients, and I mean this is usually in the very first visit when I am doing their psychiatric evaluation, is we talk about medications. We of course talk about counseling, etc. as well. But I always say meds, they are out there to reduce symptoms, right? Make it easier for you to maintain those symptoms, to cope with your issues, but they are not a treatment. As of right now, as of today, we do not have a specific treatment to actually treat any of mental illness, right? It is just symptom reduction. We can basically maintain those symptoms. We may be able to decrease those symptoms, but as far as treating them and they never come back, that's not something we can do. And for those of you who are already in family practice or those who worked in psychiatry before and you hear so much in the country, like with reimbursements and etc., one of the things too with all payers you're going to see is that a lot of payers don't necessarily reimburse as high as some medical, primarily because of a lot of psychiatric conditions are chronic. It's a reoccurring thing. There's going to be relapses and different things like that come back, and they're going to be able to they need to also continue to seek therapy and treatment with their medications. It's not something they come in, they get an antibiotic prescription, upper respiratory infection out the door, and hey, you're good to go. This is a reoccurring visit, possible, depending on the severity, hospitalizations as well. So again, telling your patients this is not treatment. This is something that's going to help you manage the symptoms. But I also try to use that phrase also is that, we've also got to put in their court as well. They have to work on doing their part, learning those coping mechanisms. How can I get through this? So medication is going to help make that easier for you to obtain, but it's not going to completely disappear. Sometimes I'll describe it as a little anxiety bug that sits on your shoulder and is always there, or that depression cloud that's still there. Maybe it's not raining on you, but it seems to follow you still. It's always going to be there. All right, so the use of pharmacotherapy approximately, and that's just some statistics for you, but it doubles the chances that a depressed patient will recover in 1 month. So actually using medication will double the chance that a depressed patient recovers within a month. And you'll learn about the 4 weeks as we continue to talk about medications. A lot of the antidepressants and things that we'll discuss usually start kicking in within 4 weeks, but some people already notice results within 2 weeks with certain medications that we choose. And so, but you have more chance of recovering from that episode if we put on some medication. So, as I was just saying, they can take 3 to 4 weeks to exert their effects. And of course, we're going to talk about the choice of antidepressants and how we're determining them depending on what the patient's side effect profile is. Maybe, as I was just mentioning, that norepinephrine is alertness and energy, and is my patient struggling to leave the bed and the house is just a mess and I haven't got up to clean it, I'm sleeping 15, 16 hours a day, I can't even cook supper anymore. Do they need that alertness energy? Is it more of a just plain simple, I just don't feel good, I've got the blues, I'm crying, maybe there's already a history of some other blood pressure issues, etc. We're going to talk about more in a second, but taking the whole patient picture and determining what medication will be best for that patient. So more information, just general information on antidepressants so you guys know is, obviously, yes, they're used to treat depression, but I want to say, and we're going to talk about this again with the anxiety lecture, but patients that say, well, I don't think I need an antidepressant, I need something to treat my anxiety. But in the reality is we have to teach patients that antidepressants are not just for depression. They also still help with that chemical or help with neurotransmitter, helping with that serotonin. The norepinephrine, high enough doses of norepinephrine can actually become more calming and more anxiety relieving for patients. And so we just need to make sure that we're educating clients on, yes, they treat depression, they can also treat anxiety. So, and also some of our antidepressants that we currently have are actually used for more than just depression. So there are some antidepressants out there that are used for, I already mentioned anxiety, bulimia, so we can actually use them to help prevent the binge that comes with bulimia. So therefore, if we're not binge eating as much, then less likely to purge. Fibromyalgia, smoking cessation, PMDD, diabetic neuropathy, chronic pain, enuresis even. So additional off-label uses, just so you guys know as well, there are certain things that we can use to help with migraines, ADHD, irritable bowel symptoms, which is almost, I always like to say, a double-edged sword. You know, it's just saying that a lot of times you'll see people with irritable bowel, if it's especially IBS-D, suffer more, or just so happen to also go through depression. But in reality, too, sometimes when our nerves get the best of us as well, that can also cause our stomach to upset and to have more symptoms of the nausea and diarrhea. And also, a lot of our medications can help with premature ejaculation. Now, on the flip side of that, unfortunately, adverse effect is sometimes we're going to be causing issues where we have a delay in orgasm, or we cannot orgasm, or we're having erectile issues. And so that's, you know, unfortunately, it's one of these things that medications, you know, we trial them, we go through clinical trials, they have a good purpose, but along the way, I used to describe it as they kind of bump into some other parts of the brain that, unfortunately, that's how we get side effects. So along the way of getting to that pathway, or that part of the brain they need, they may have bumped another one, and we have to kind of deal with side effects sometimes. So clinical guidelines I want you to please remember is, and obviously I've got it with asterisks on it, but the most common clinical mistake leading to unsuccessful trial of antidepressant drug is using too little for too short of time. Okay, so too little, too short of time. I have seen patients, and here recently I saw a teenager that was started on a very, very low 25 milligrams of Zoloft, and as we talk about it more, you know, after the age of 13, you don't have to necessarily start that low. Under 13, you could, but had been on this dose for several months and really had begun to have passive suicidal ideations, etc., even on treatment. The dose should have been increased. And so that's a little low for the age group. And if you're going to do that low, maybe to get them back in a couple weeks and look at increasing it. And too short a time, you're also going to see issues with patients they take something from it that this doesn't work. This doesn't work. I've seen it on my end just as a psychiatric prescriber, those coming to me from PCP offices, and just, I mean, multiple, and they'll tell me, well, I tried this. Oh, wow. Well, what dose of Prozac did you try? 20, we didn't work. It just switched. And then I've also tried some Balto. I think I've done Zoloft Paxil. Oh, yeah, I don't want to do Paxil. Maybe gain weight. But we go through the list, and then I really find out, like, well, how long did you stay on it? What dose did you try? And a lot of times I will find out that it's just they've tried maybe 1 or 2 doses and stopped. 1 or 2 doses and moved on, and maybe for a month, and just kept on without staying with that medication and possibly trying it for longer than a month and pushing it to what it could go, just leaving it. So, okay, so again, just one of the most common mistakes, okay, too low of dosage for too short of a time. So, and that's kind of where it leads me into the next one. So I've kind of have arrows, is because I've already mentioned, you know, a lot of times I had actually a psychiatrist that taught me, or he used to like to say, push the dose until you either get side effects or you have treatment. You know, they're maintained with their symptoms. And I thought, oh my gosh, you know, I don't want to push it to the very high dose, but in reality, I understand what he meant. He didn't necessarily mean always push it to the maximum dose, but he just wanted to make sure that you're going to use the medication to its full potential, and to get those wanted, I guess, the whole reason you're prescribing the symptom relief. Excuse me. So now, like I was just saying, that kind of leads to the green box. Alternatively, they begin improving, and maybe you just put them on, they're on Prozac, and it goes from as low as, you know, even 10 milligrams, you could, more use for children, but up to 80 milligrams, and maybe we find improvement at 40, and they're doing really good. They're stable. They're working. They can concentrate. They can focus. Their appetite's been more maintained. They're sleeping through the night. You know, things are great. Less anger, less irritability. Do I need to continue to keep pushing and trying to tell them, no, well, we got to push it all the way to 80? No. Okay. So if they find that they've getting good benefits from the 40, then leave it at the 40. Okay. All right. As I mentioned, red box, so I was mentioning the story about my adolescent example. Appropriate doses within 2 to 3 weeks. If you can at least give it 2 to 3 weeks, then you have a little more efficacy, a little bit more room to go ahead and increase the dose. Sometimes you'll see providers who will start a lower dose, they'll do it for a week or two, and then go ahead and go up to the next dose and see them back within 4 weeks, depending on the age of the client. Obviously, with children, we want to see them back a little bit sooner because of the risk. I'll go ahead and mention this now, is the human brain is not fully developed until you're 25 years of age. And so when you see warnings and things like that for child adolescents to taking antidepressants or seeing these commercials, it's because we honestly don't know completely. There's not enough research or trials to know really what is these medications going to do to the brain. And even with trials that we do have, we're still not 100% guaranteed on how it's going to react on a child's brain. So, but 2 or 3 weeks, you can get them back, look at them. You can increase if you need to, but also please rule out noncompliance. That's one of the things, like, oh, we need to move up. Oh, we need to move. Well, I'll be honest. So I can never remember it, and I run out the door, and I just cannot remember it. Well, okay, that might mean why it's not working. Instead of before you change to a different medication or increase it, do rule out noncompliance. I did put in there, they're having more and more different things, like you can test their DNA with the 23andMe, you can do the plasma concentrations and drug levels and etc. And I think that that's going to be a really great thing as it continues to get more, I guess, when they actually do more research and continue to improve. I will be honest, I have run different tests in the past before through practice, and sometimes they're fairly okay, but there's been times where their reports have said, oh yeah, this medication is going to work best for your patient, but in reality, it's not always going to work best for your patient. I've actually had patients who are like, well, we've tried that before and that didn't work for me, or oh, that's the one that gave me side effects, or there's one that might be flagged, oh, do not put this one on your patient that they can't tolerate, and that's actually been the best one. So I think that there are still some improvements that need to be made as far as those testings, but if you want to check a level in their system, and also maybe to kind of, you might be able to call them out on it, but I don't want you to just base it off that either. Some people are higher metabolizers, but these are just different ways that you can look at. I honestly, at the end of the day, especially with psychiatry, this is probably the one field of practice that I tell patients that it is not, we have to go by more subjective data, I'll say. Okay, we don't have as much objective data in our prescribing, just the field in itself. We can't just check your blood pressure and say, yep, your depression is better. Great. Oh, your sugar level's better when we, take a glucose. We can't do that with depression and say, oh, your schizophrenia is so much better. Look at that. It is more symptom-based, listening to the patient and what they feel. And a lot of times I'll actually ask mine, from when you first started seeing me, what percent do you feel like you're better? And where do you see yourself? What percentage do you want to see improved? So always be listening to the patients. All right, antidepressant duration prophylaxis, it just honestly varies on the patient by the books. So Kaplan and Stoddard actually said at least 6 months of length. I had always been taught at least a year. I will still tell patients that really you probably want to give at least a year of treatment after a depressive episode. However, there are those that they feel that they're ready in 6 months, and there are ones who don't want to be on medications long term, then that's something you can discuss. But you really need to make sure, is this a true single episode, or is this someone who's reoccurrently dealt with depression? If they've reoccurrently dealt with depression, 6 months is not going to be your answer. Maybe it's a one time you went through a divorce or grief loss and never got over it and had some depression, and you had enough symptoms to actually diagnose it as major depression. 6 months may be maybe okay for you, but for someone who's continually recurrent, either they need to stay on the medicine, not even try without, or at least a year. Obviously prophylactic, and that's where I say stay on it, because a lot of times I tell patients it's just, and then there are more studies, we're going to get into antipsychotics and things too with long-acting and the injectables, because there's actually research, the more that you have these incidents of these relapses, there's actually more damage to the brain. And so that's kind of where even depression, okay, maybe I'm not saying comparing it to psychotic relapses, but the depression, all that anxiety, the lack of sleep, if you think about those things, you reoccurrently are going to have these relapses. It's more damaging over the brain over time. So to go ahead and have treatment on board that may prevent you from having to deal with it in the first place, or at least reduce the amount of of the times that you've gone through depression or the severity when they do come back, they're a whole lot less severe than they would have been had you not been on medication. So, you know, and that's kind of where I was just saying the severe depression. If you've had severe suicidal ideations, you know, again, when it's reoccurring, if it's been severe enough, if you've had a past attempt, your recurrent ideations, you know, you're probably somebody who needs to be on prophylactic treatment and not just try a 6-month regimen trial and be done. So depending on your antidepressant, can you just stop it if there was like side effects or something? We'll go into that more about which ones, but if you've been on it and you're like, okay, I think I'm ready, I can come off my Prozac now, you know, you don't want to just stop it, and then we have rebound depression that possibly can happen. So you do want to try, like, okay, we can start reducing this. And a lot of times, if you're actually wanting to get it, the patients want to get off the medication over 1 to 2 weeks, reducing it every few days, or maybe depending on what the dose is, maybe a week at a time, and then follow back up to see where we stand. I've actually even done slower tapers before while I'll cut it in half and then maybe see them in a month and kind of go from there, just depending on the history of the patient. You know, please, you know, when you're practicing, make it patient specific. And I've always said, and I'll still stand by, not everything is exactly by the book. You know, you've got to center around your decisions on that particular patient. All right. So, some antidepressants. Now to talk about drugs. We've talked about just a little bit of going along the way of some parameters of treatment and some ideas and indications on treatment with them. But let's go over classes. So we have SSRIs. I mentioned the selective serotonin reuptake inhibitors, fluoxetine, which is Prozac, sertraline, which is Zoloft, citalopram, Celexa, escitalopram. They're pretty much sister drugs. That's Lexapro. Paroxetine, Paxil, fluvoxamine is Luvox. You have your SNRIs, serotonin norepinephrine reuptake inhibitors, venlafaxine, which is your Effexor, duloxetine, Cymbalta, and desvenlafaxine, again, another sister drug. That's your Pristiq. TCAs, tricyclic antidepressants. You've got amitriptyline, nortriptyline, imipramine, doxepin, and desipramine. Just so you know, like TCAs, you're going to see some of these still in practice, but you're not going to see them as often as you're going to see the SSRIs and SNRIs. TCAs are, we're going to learn here in a minute, there's some side effects and things that come along with those, so you just don't see them as often prescribed in practice any longer. There are what we consider atypicals, or those antidepressants that may work a little bit different than others. The bupropion, we mentioned earlier, that's Wellbutrin and NDRI. Mirtazapine and trazodone are following what we call a tetracyclic type family, and they're a little bit different. And then the word toxetine, and I may not be able to say that completely right, but that's that new Trintellix. And just heads up, your book has that. The date that your book came out is before Trintellix actually had a lawsuit over being too close to the name. It used to be Brintellix. It was too similar to another name of a medical medication, so they did change it to Trintellix instead of Brintellix. But in your textbook, it will still say Brintellix. MAOIs. Monoamine oxidase inhibitors. You've got Nardil, Parnate, and Marplan. I didn't put on there because you're not going to see it as often, but selegiline as well, that is an option. And I think I did include it when we actually separate into MAOIs. And then Spari, which is just kind of, it works a little different. It really, a lot of times they'll include vilazodone or Vibrad under SSRIs still, and I still would consider that. It just has a little bit different in its reaction. All right, so there those are again, so you can load. I did both trade name and generic just so you can kind of get used to either one with boards. A lot of things, especially I knew even with undergrad, they are really solely focusing on generics, and on boards for the NP boards, for the most of the time, they are focusing on those generic names. So, but this is because in practice, a lot of times you've probably heard around, or family members who suffered, or if your individual have suffered, you've heard the brand name, so now you can start to associate the generic. All right, so indications for use when we're looking at, we're starting with SSRIs first. So selective serotonin reuptake inhibitors, what are they used for? For depression, anxiety, OCD, panic disorders, body dysmorphic disorder, bulimia, PMDD, premenstrual dysphoric disorder, and PTSD. Some adverse effects. Let me start by saying SSRIs are one of the lowest side effect profile antidepressant choices, okay? They are the least likely out of their family of antidepressants to overdose, okay? So they're a little bit less toxic when it comes to overdosing versus another family we'll learn about here in just a second. And so they are, obviously, they are, right now, actually, that's the only FDA necessarily approved medication for depression, anxiety for children and adolescents, if we're thinking about the side effect profile on these medications. So typically common adverse effects. And I tell patients, hey, first couple days starting it, you may have, especially when your body's trying to get used to it, you may have some headache, a little dizziness, dry mouth, you can have a little upset tummy. It might be a little diarrhea, sometimes people constipation, nausea. Usually those side effects will fade within 4 to 5 days after starting the antidepressant. If it doesn't, that's when I encourage patients to go ahead and call back to the clinic, and we'll kind of go from there, and we'll see, is it something that, is it bothersome? Are we getting, at that point, you're probably not getting much benefit yet, but you may, and kind of have that conversation if it's worth continuing, or do we need to find something else, or as I like to say, the plan B. But there are a couple of SSRIs that can prolongate the QT interval in the heart, and that is possible. Again, it's not very prominent, and I'll go about it here in just a minute when I talk about the medication, but it's a dose dependent, or combined with another medical medication. Can cause actual more agitation, anxiety, depending on the disorder and the patient's reaction to the medication. And that's why I always say it's patient-specific, guys. I mean, these are common, but everybody is different. I mean, I can see something with one patient that never touches another. One person will say, hey, have you had these? It made me do this, and it may not make somebody else do the same problems. Sexual dysfunction, I've already mentioned, is a possibility. Some of the SSRIs can be a little sedating, so they need to be dosed at bedtime. But then on the opposite end of that, you guys, I'm like, oh, that usually makes everybody sleepy. Well, it didn't me. It kept me awake, so I moved it to the morning. I mean, again, patient specific. And a lot of times my teaching is, well, we'll start this in the evening because most of the time this can be sedating. However, keeps you awake, you're wide-eyed, it gives you more energy, move it to the morning. You got to do what's best for you, and that's what I tell the patient. All right. So here is something I'm going to say that, yes, we're going to teach, we're going to go over it. Do we actually see it in practice? I'm going to knock on something here. Not specifically have I actually seen this in practice. There was a belief about one of my patients who was taking a combination of Prozac and Adderall that possibly contributed to serotonin syndrome, but any of the psychiatrists and others that I worked with just didn't believe that is what happened. And as we go over the symptoms, it makes sense because he didn't really exhibit specifically these criteria, these symptoms. But in just the low of whole, we don't really see that. A friend of mine has been practicing psychiatry as a nurse and as a nurse practitioner. She's been in the field for over 30 years and never once has actually seen serotonin syndrome. However, it may be because we are more mindful in our prescribing. We know which things to combine and how many serotonergic agents we can combine at once, and what are those early symptoms of possibly leading to serotonin syndrome. But here's the big boy. So serotonin syndrome, a lot of times, if it has happened, okay, and I mean, people have seen it, just not specifically in my case or my friends, as I was mentioning, but more than one serotonin-related medication, okay? So maybe more than one antidepressant put on together, or you put an SNRI and an SSRI, or maybe you have some buspirone, which we'll learn about a little later, hits serotonergic type properties. The Adderall could with certain things, but does that mean just because one person can't tolerate these two, does everybody? No. So I don't want to freak you guys out about that, okay? I want you to be able to treat the patient, but just be mindful when you're prescribing. St. John's wort is a natural herbal over-the-counter. Remember that any of your over-the-counters are not necessarily FDA approved, and so we really don't know exactly, have they been through the testing and trials? We don't know exactly what they're going to do to the body and the brain or interactions with other medications. So, but St. John's wort can have serotonergic effects, and sometimes people choose to have that natural type herbals. They would rather more alternative type therapy for their treatment of their mental health. And we'll actually, when we go to module 10, we'll talk about more complementary and alternative treatments to mental health. All right, SAMe, again, similar. Concurrent MAOI, and we'll learn about those in a minute, the reason why. And then lithium is possible. Now, do I have patients on lithium and other SSRIs or SNRIs? Absolutely. I have a patient that I actually saw recently who's on a combination of lithium and an SSRI and absolutely doing wonderful for the first time in a long time. So it doesn't necessarily mean you're going to have it. But if you were, let me start with saying one of the earlier symptoms, okay, earlier symptoms of serotonin syndrome is when they begin to have a lot of diarrhea. Notice that's listed, diarrhea and cramps. But diarrhea, and if they're having a lot of with the medication, that might be one of those early symptoms that you may need to look at stopping something before it does progress. If it were to progress, then you're looking at the autonomic instability. So breathing and blood pressure changes. They can be variable. Okay, it's not necessarily always high pressure, always fast breathing. I mean, they can be just, maybe it's normal and then we're rapid, we're low. It's just, you know, it's not stable. Be restless, agitated. They may have some jerking motions. Now, here is one of the big keys, and I learned a long time ago, to rule out whether this is really serotonin syndrome. Do they have hyperreflexia? Sometimes we actually had a psychopharmacologist come speak to us at a drug luncheon, and that was one of the things to rule out. His office, the ER, actually had sent patients saying, "Oh, it's your mental health meds, it's your psych meds, it's all, you know, psych." He saw the patient, you know, they're like, "Well, I think I'm having serotonin syndrome," and he got a good clinical description of what was going on with the patient. And it didn't sound like serotonin syndrome to him, and so he actually tested his reflexes, and he's like, no, if it was true serotonin syndrome, I mean, you would have 4+, I mean, just absolutely large reflex reaction. And actually sent him back over and got more testing. A different person laid eyes on him, and there was actually some more cardiac issues going on. So that's one thing is, you know, really kind of rule out. Does that mean every person's going to have that symptom? No, but that is one helpful type key. Hyperthermia, so there's usually a fever. Now, when I say that, you're going to learn about something else when we cover antipsychotics later on. That's called neuroleptic malignant syndrome, or NMS. And now those are usually really, really high fever. For this case, for serotonin syndrome, it may just be, 99.7, 100.8, you might make 101. I'm not saying that you're going to have 105, okay? Diaphoresis, so they're sweaty, there's tremors, there's chills, the ataxia, if you remember, you put your hands straight and your arms straight and your hands are shaking, loss of body control, body movements, headache, can't sleep. So what do we do? Well, number one, in any situation, okay, and if I'm asking you what is the treatment in serotonin syndrome, stop the agent. Stop what is causing it first, right? Because if you continue it, then we're doing no good, okay? Stop the agent that's going to be leading to that. You may have to give muscle relaxants, okay? And if you think about the jerking and the reflexia and the muscles tensed up and everything, and then serotonin blocking agents, there are certain different things such as periactin that can actually be used to actually kind of lower the serotonin or block it. And so that can come on down. Oxygen, IV fluids. Think about that. I mean, obviously getting good breathing, getting the fluids, get things filtered out quicker through you. They may do medications to control the blood pressure and heart rate. Gosh, if really bad, you may, have to have a breathing tube, be on the vent. Course of treatment, usually mild cases resolve 24 to 72 hours. Once you stop the agent, moderate can take up to weeks. I'm grateful I haven't seen that thus far, but again, that's why I don't want to not you take it seriously, but at the same time, I don't want to scare you from being a clinician as well. All right, and there's just another little mnemonic for those who are picture, so that's for you who are more visual learners. All right, so if we're looking into the pharmacokinetics and the pharmacodynamics, what is the drug doing to the body? What is the body doing to the drug, right? Or how is the body reacting to the drug? So let's start out with the half-life. And if you guys probably remember, maybe from nursing school, or for those of you who've gone to family practice, kind of the rule of fives. We're trying to kind of figure out how many days it's going to take to get our system, how many days it's going to take to get out of our system. A lot of times we'll look at that half-life. Remember, for those, the half-life is, halfway. I mean, halfway where the point is, the drug is halfway, out of your system. So the half-life of Prozac, okay, I'm just going to give that as an example, 4 to 6 days, okay, that is actually one of the longest, and now that was by your Kaplan and Sodek textbook. I will tell you a little bit, sometimes in your stalls may actually vary a little bit in that. I think, most data shows within 4 to 5 day half-life. Paxil or paroxetine and fluvoxamine Luvox have the shortest. You will hear that often, especially those who are non-compliant with Paxil or paroxetine. You're going to have rebound symptoms quicker, and you're going to notice if you miss 1 or 2 days, you're already going to feel it, versus the Prozac. It may take the 4 or 5 days before you really notice that, oh my goodness, I've got to take the medication. I haven't been taking it. So those things can be really important for us in practice to be aware of those half-lives when we're making those decisions if we're working with patients who are typically non-compliant. Withdrawal symptoms also related to the half-life. Half-life is very important to know. How fast can we switch a drug over? Do we actually need to wean the drug and titrate down and increase the other? Do we need to completely stop the medication before we start another? Or can we just stop today and start the next one? Those are important things to know. So most of all SSRIs are metabolized by the liver and by specifically the CYP450 enzymes. If you don't remember or going back over neuroscience things, so that can mess with our medications. Sometimes medications are inhibiting metabolism of other medications, and sometimes they're inducing it. And so it actually runs the medication, other medication, to not be as effective. A lot of times people will coincide these with seizure medications and birth control and things like that. Our SSRIs, unfortunately, can be one of those that can inhibit other medications. So, medications, SSRIs in general, very, very little effect on norepinephrine or dopamine. Citalopram and escitalopram, Lexapro, Celexa, okay, they specifically really target, out of all the SSRIs, they are really more of a selective inhibitor of the serotonin itself. So they are the strongest inhibiting action of the serotonin. All right. So some precautions that we do have to watch, though. Obviously, I already mentioned earlier, increasing the suicidality risk in children, adolescents, and young adults. Monitor as they may worsen. Here's the thing with that. Again, everybody's different. Is this medication actually blunting me? Is it making me where I have no care at all? I lost somebody close to me and never had a feeling, never shed one tear at the funeral. We need to be aware. As I tell patients sometimes, I do not want to zombie your feelings. Do I want things to make more manageable and calm these down? Absolutely. I do not want you zombied. I want you to have care, and I want you to have feeling. We also need to monitor too, as this kind of goes back down to contraindications, but we have to be very, very careful sometimes with SSRIs in particular, with those with bipolar I disorder. Without a mood stabilizer on board, sometimes we can actually send somebody into a manic episode where they've actually become more anxious or more hypervigilant, not sleeping, run around, more aggression and issues, and possibly even psychosis with the induction of the SSRI. And I'll share more stories as we get to mood disorders and things about patient examples and scenarios as well through practice. So also, have they ever had a hypersensitivity SSRIs, meaning, have they ever had allergic reactions to specific ones, and we know that they work very similar. Again, hey, I'm allergic to Effexor. Well, Prestige is the sister. I'm allergic to Celexa, and Lexapro is very similar, so those keep in mind. And MAOI, we'll talk about those again more, but usually if you're going to go from an MAOI to an SSRI, which MAOIs, y'all, are very, 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 very seldom prescribed now, if any, due to side effects we'll learn about here in just a second. But within 2 weeks, that is one of those you're going to have to stop and actually be without anything for a couple weeks before you start anything new, because of that risk of serotonin syndrome is higher in that aspect. Any kind of severe liver, kidney issues, and we just need to be very cautious. It doesn't mean just because you have issues we can't prescribe it, but we're going to have to be more mindful, lower dosing, but those may be a contraindication if it's very severe, if you're actually in certain acute liver or renal failure. So dosing, just to kind of give you a dosing chart. Now this is per APA, American Psychological Association, but just so you are aware, there is a 10 milligram form dose of Celexa that is provided. It's just usual dosing is 20 to 40, but again, this is in adults, okay? So kiddos may have 10 as their usual. And then also Prozac also forms as a 10 milligram available, again, more kiddos. Sometimes I'll see that OB-GYNs will sometimes add, I notice, like 10 milligrams to some females and things like that. And then let's try to make sure I've got them all. Of course, Zoloft again comes in at 25 milligram. Sometimes people, even I've seen, like when it's real young children, maybe at 12.5 milligrams, they begin if they're under the age of of 13. And so know that there are more dosing available, but these are the averages for the adults. All right, so drug selection, like, okay, I need to know how fast do I need to move? What am I choosing? But this is just kind of a little scenario with no specific optimal antidepressant, necessarily not one drug in mind, but you know, any improvement, no improvement at all in 2 weeks. I mean, like I said, 2 weeks sometimes before people really, I'll tell people after about a week there's a very slight difference, sometimes 5 or 10%. If it's the right drug, we're on the right track. 2 weeks, maybe I'll get to maybe 20%. And I love when they came back. I like to tell them 40, 50% difference, if not better, if not more. I think absolutely nothing in 2 weeks. And that's the point of time where if you're getting them back for a 2-week check, then you might want to try to increase it just to see. Don't just give it up though, okay? So again, no improvement 2 weeks, probably look at maybe increasing it before we move on. If they've got some moderate improvement before 4 to 6 weeks, okay, great. Maybe we need to increase it again. Look at other things that we can do to tack on to that. Maybe it's they're actually managing things a whole lot better. Hey, you've come back for your 4-week checkup. Maybe I saw you in 2 weeks when I initially started it. 4 weeks later, I'm seeing you. And hey, I think that you're right. Like maybe you started Celexa 10, and 2 weeks later you put it to 20, and you're like, I think I'm not better. I'm not 100%, but I'm managing it. I'm okay. Continue it on. Maybe get them back in another month and let's just see. Okay. Again, if we're still maintaining, this is where that percentage thing I mentioned comes into play. So maybe they're like, yeah, I guess I'm probably 50, 60% better. And maybe they're just still hanging around that number and they really have not gotten to maybe closer. Maybe they wanted to be 85, 90% better. You know, I always tell patients, maybe it's not 100%. Then that's a discussion of, do we need to increase again? Okay. Because depending on what dose you're already on at that point, or maybe we need to, just depending on the percentage. If they are, you guys, if they're probably like, hey, I'm managing things, I'm 60, 70% better, I would increase it. But if they're still hanging around 20%, 30%, yeah, look at it. Again, look at your dose. How fast did you move? What type of medication is this? Okay, there's a lot more dosing that there's available in Prozac than there is necessarily Lexapro. Okay, so depending on the medication, depending on the symptoms of the patient and how much that they've improved, make that decision whether you're going to increase it again or do we need to find a different medication. Now, where it says combination therapy, there's also to the point where maybe we have gotten to the max. We're maintaining about 70, 80%, but maybe enough of it is still that percentage that still is there, that 20, 30% is frustrating to them. It's like, gosh, I just wish this little bit was better. That's that point. Well, do we need to add something on? Maybe something that because they've always still struggled with energy, but they feel a whole lot better overall. Maybe is it the sleep issue? Maybe is it that, I don't know, maybe the depression itself is just not completely gone. Then there are other things we can do, and we'll talk about atypical antipsychotics more when we get to that unit, but those have a lot of efficacy in research that are coming more and more as options to add on to antidepressants to help treat depression. All right, some more clinical tidbits just so you are aware. So fluoxetine, less likely to have weight gain. So a long time ago, that's what I was, they actually used to say the story of when Prozac first came out in the 80s, it was actually used more as a weight loss drug and everybody started feeling better. And so we now use it more as an antidepressant. But for those who maybe already struggle with weight issues and things like that, Prozac may be a good option. And just to also tell you, it's on the third bullet. I guess I should have put those together, but it's also more activating. So for those who maybe struggle with energy as well, and they're worried about their weight, then Prozac may be a good option for them. They could get up, they can take in the morning, a little more activating and less likely to binge, and may help you to possibly lose weight. I never promise it, but I may just say it maintains your appetite a little bit better and less likely to gain the weight. Paroxetine or Paxil usually does stimulate the appetite, and people will say, call Paxil pack on the pounds. So just being aware. And remember, it has a very short half-life. So there is a CR version that's a little bit better as far as controlled release. And sometimes if I'm going to use that one, that's what I'd rather do than the short-acting. Again, you're probably going to start short-acting, make sure there's no side effects. If they tolerate well, then you could go on to the CR. Escitalopram, Lexapro tends to be weight neutral, and for the most part, I will agree with that. I don't usually see when people are going, oh gosh, this is going to make me gain a bunch of weight. Not usually. It again depends on the person. Citalopram and sertraline, Celexa and Zoloft, more often given at night due to sedation, and Lexapro, honestly, too. Maybe, buyer book may specifically not have listed that, but in reality, it is. And even I'll a lot of times dose Paxil also in the evening. One of the very few, I guess, SRIs I actually put in the morning is Prozac. For me, that's really the only one that specifically that I see is activating. But again, there are some people who will like to take their Lexapro and things like that in the morning. So, withdrawal from SSRIs. Okay, I want to make sure I clarify this. Yes, I have don't stop abruptly. Does that mean that you're going to go in acute withdrawal? No. But what that does mean is, again, it goes back to that whole rebound depression, depending on what dose you're on. And honestly, it depends on what SSRI you're on. If you're going to stop abruptly with Prozac, well, half-life, rule of fives, it might take, again, we're taking, at least 2 weeks to even get out of your system, okay? But maybe we abruptly stop Paxil, okay? You're going to know that fairly quickly, and within about 3 to 4 days, not even that, 2 to 3 days, you can even start to show some withdrawal effects. What did I say, 15 hours for withdrawal, so times 5. 75 hours, so about 3 days, you're already going to notice and have the withdrawal. And you may feel kind of flu-like, right? A little weak, can't concentrate, you might be nauseous, vomiting, shock-like sensations. Sometimes people or patients have described those as brain zaps, and I never had really heard of this when I first was going through school until more of practice, and it is something that people report specifically with Zoloft or sertraline if you just abruptly stop. Because Zoloft can dose up to 200 milligrams too. If they just abruptly stop, it's almost like people say they turn their head and there's these little electricity feelings, and they don't know how else to explain them besides brain zaps. Can be more irritable, anxious, can't sleep. Well, yeah, you're coming off. Crying with no reason, at the drop of a hat, dizzy, So these are all things, and that's why we might want to caution and try to explain to people, don't abruptly stop your medication. Number one, because I don't want your rebound depression to happen, but number two, you may actually feel worse than you did with the medications or before you even started them, is what I like to say. All right, so SNRIs, our next class, serotonin norepinephrine reuptake inhibitors. So we've got the Effexor, Pristiq, Cymbalta, and I included, it was not in your Kaplan and Sodic book, but Fedzima. That is, I'm not going to call it newer, but when I was doing more of the private practice setting back in 2015, it'd probably been out maybe 6 months to a year at that point. And I've used it quite often, but it is an SNRI, and right now it actually has one of the highest norepinephrine. It hits the norepinephrine highest or more severe or more reuptake inhibition properties. So that is one of those, and I don't see it as often used as others. However, it's out there. So some indications, what in the world do these treat? Well, they can help with depressive disorders, again, anxiety disorders, and this is where it adds a little bit of social anxiety, actually. There is social anxiety, I will just tell you, is one of the hardest things to treat, especially with pharmaceutical agents, but however, social anxiety can, or has been, indicated, or SNRIs have been indicated for social anxiety. Pain management, so that was really interesting. I don't know if you guys remember the commercial Depression Hurts when Cymbalta or duloxetine had that commercial, and that was because, we came up with an antidepressant, and now we're noticing people are getting some nerve relief, nerve pain relief. Those who deal with diabetic neuropathy, fibromyalgia, chronic pain, sciatica, etc. We're noticing that they're getting a reduction in those. And I tell patients too, it is not necessarily going to treat, again, none of these medicines treat, they're not treating the pain, but it sometimes helps to manage it. And adversely, I'm going to tell you too, kind of coincidentally, it's because also when the depression is better, you feel like you're going to get up, you're moving better, you're more active, your joints are not as stiff. So I kind of feel like there's a little bit of combination there, but even for those who don't necessarily deal with depression, you see some pain physicians and pain management clinics who will pull out Cymbalta to use for pain relief. All right, so what side effects do you expect with an SNRI? Okay, so now we're reuptaking or inhibiting the loss of two neurotransmitters, okay, serotonin and norepinephrine. So now we can have some nausea, once again, I think, and honestly, y'all, like just about most other medications, I think nausea, vomiting, diarrhea is just about every medication. And so that's pretty much safe to say if you ever like get lost, like, I get sidetracked, like I'm trying to remember all the side effects of the medication, headache, nausea, vomiting, diarrhea, just about every single one of them. Again, usually transient, usually initially when you're first starting it, you're getting used to the dose, or as you're going up, maybe if you made a dose change and you're increasing it, it's always possible, but usually it subsides. And it may be just the patient needs to eat with it to prevent the nausea. It may be that, again, just getting through it, give it some time. They may move to bedtime to help the side effects, depending on what drug it is. I will tell you an SNRI, where we get down to the insomnia and somnolence side effect, they are more likely to be activating. Remember, they're hitting that energy alertness chemical. And so they are more likely to keep you awake. Although I do have a very small percentage, but I do have some that do. They take it at bedtime. It doesn't bother them. Well, great. But majority of individuals need to take an SNRI in the morning time. Now, we are hitting that alertness and energy chemical. So sometimes that can unfortunately make us more anxious, depending again on the patient. Because in high doses of norepinephrine reuptake, then we can actually be more anxiety relieving. So it really, again, on the patient. Sexual side effects, again, possible. Sweating. I've heard that, and actually I didn't add that to SSRIs, but Prozac can actually, you might have patients who complain of sweating with Prozac. And then it can, because again, we're hitting that norepinephrine, alertness, energy chemical, right? Stimulating, we can increase that blood pressure as well. So just need to keep an eye. Not as often that we see that specifically with an SNRI, but just keep an eye. Discontinuation syndrome. Now, I said SSRIs. It was one of those more of like not wanting the rebound depression and possibly some of the effects. SNRI, you abruptly stop. Yeah, it's a side effect. Yeah, the recurrent rebound depression, that's an issue, but the side effects, you're not going to feel so great. Especially Effexor gets a bad rap specifically because coming off of Effexor sometimes can take, and depending on what the dosage that you're on of Effexor, if you're already up to 225 or even up to 300, as the APA says you can use, then it is that can be over a few weeks that you're actually having to wean to get off of that because of the side effects. So again, maybe feel dizzy, dry mouth, you can't sleep, you're nauseous, you're more nervous, sweating. A lot of things, just like SSRI, it's almost like those people say those flu-like symptoms. And if anybody knows, like when we'll talk about more too with withdrawing from opioids and things, very, very similar to some of those side effects. And then sensory disturbances. People sometimes feel like, I don't know, it's cloudy or they're not touching, and just even the taste, just everything is off for them. Their vision can be scattered a little bit. And so those need to be tapered. All right, so SNRIs. Again, I said dual action. Looking at two different agents that it's helping with, okay? It has a little bit of a third with that dopamine on there, but very, very small percentage. So it's more focused necessarily. It's really hitting that serotonin and norepinephrine. And then, I'm trying to think, make sure I want to give anything else. That's essentially what it is. When we're looking at SNRIs, pharmacokinetics, pharmacodynamics, again, thinking about, and that's the whole reason I wanted you guys to create that neurotransmitter mind map. It's because I just want you to have a quick kind of reaction like, okay, I understand what norepinephrine does, and when we don't have enough, this is what happened. Or serotonin, we don't have enough, or we may have too much. And dopamine, we don't have enough, we may have this, and we have too much. For example, dopamine, maybe we don't have enough, so maybe we can't concentrate or focus. Maybe we're attention deficit disorder, which we'll learn about more, right? Or maybe we're Parkinson's disease for medical providers, and then maybe we have too much. Now we are psychotic, okay? So kind of being able to associate what those neurotransmitters being too much or too little, what do they have, so that you can also help to pick out the medications they need. Usual dosing, just to give you a guide. Am I necessarily going to test you on specifically, like tell me the usual dosage range for? No, okay? But I want you to have an idea. I want you to know the clinical concept of starting and not using too small of a dose for too short of a time, right? Okay, I like having the concept and knowing what these drugs could go to, and so that you're not just starting 30 milligrams of Cymbalta and giving up on it, okay? Or we did 30, we went to 60, and we're like, oh, it didn't work. There's a whole lot more room to grow. All right, so some more clinical tidbits. SNRIs can be chosen when the person may not have any benefit with an SRI. One variant is melancholy, like I was saying, kind of just everything is gloom, a lot of negative symptoms, everything's just There's no maybe no care there, no enjoyment, lack of affect. The affect is that expression and look on their face. Helps for those with, again, I said depression and chronic pain. And there are, especially, again, they couldn't officially say because FDA has not necessarily made it approved for ADHD specifically. Like when I was talking about Fetsima, it has one of the higher norepinephrine concentration or type action. And there is some theory there. And in fact, there is a drug that we'll learn about with ADHD medications, Strattera, that is targeting that norepinephrine that actually improves focus. So focus and concentration may be able to be improved in an off-label ADHD treatment. So, all right, that's SNRI. So now going on to tricyclic. Okay, I mentioned earlier when we first were talking about these that unfortunately there are a lot of side effects that sometimes can come with these, and so you just don't see them in practice as often. Doesn't mean they're still not used, but they're not, I will say this, when you do see them used in practice, they are more likely used maybe for pain relief, right, for sleep, maybe for nocturnal enuresis, but you do not usually see these specifically to treat depression anymore. It is a whole lot more rare that we're dosing them high enough to do that. So there's the list again if we wanted to go through them. All right, what do they treat? What are they for? So again, depressive disorders, anxiety, OCD, panic, PTSD, and then again I've said off-label, sleep, nocturnal enuresis, and nerve pain. How do they work? Blocks the norepinephrine and the serotonin. Honestly, so, and that just that pillow sit, but if they were to come out with this class today, these medications, they would probably really honestly fall more in the SNRI category. They're slightly a little bit different in the way that they work from an SNRI, but essentially doing the same thing. Okay, just increasing the synaptic concentrations of those. Okay, they do undergo liver metabolism by the CYP450, so again, may need to adjust the dose depending what other medications, and their half-life, depending on what they are, 10 to 70 hours. So we've got, wow, really long half-life on some and then really short half-life on those others. So here's these adverse reactions. TCAs are very drying. I just want to say that. I'll say that again. So TCAs are very drying, okay? So they have those anticholinergic effects. If you remember those medications, and we'll later talk about benzotropine, which is cogentin, and other anticholinergics. And it used to be that whole dry as a bone, mad as a hatter, red as a beet, all those anticholinergic type side effects and feelings. And these are a lot of times caused or as a side effect of TCAs. So it can be dry mouth, constipation, blurred vision, urinary retention, and can even be delirium. If we think about too, not staying hydrated enough too, and then you've got something that's drying, can lead to delirium. There are cardiac effects. That's what they are known for more. We have to be very, very cautious. There's tachycardia. It can change the cardiac rhythm. There's QT prolongation possibility, risk for that. There's also changes in other waves of the heart, and so we've got to just be more mindful. Orthostatic hypotension, if you guys remember standing up too quickly, or when you stand up and your blood pressure falls, you maybe feel more weak, people need to be cautious and not just pop out of the bed, and so there may be more teaching that to sit on the side of the bed and then to slowly stand up. Are usually more sedating, can have some tremor, weight gain, unfortunately is something that comes along with these sexual side effects. And here's another big, big, big star, okay? So another asterisk is more lethal in an overdose. So you've got to think about, too, when you're choosing the right regimen for your patient as the prescriber, are you going to someone who's literally has a history of overdosing before on pills? Are you going to choose a TCA or SSRI? Just keep that in mind and be more mindful. Have I seen TCAs prescribed for someone who had a history of overdose? Yes. However, they may have a reduced amount at the pharmacy. You may have where they're only getting a week or two of prescriptions at a time instead of their monthly prescriptions. But most times than not, the answer is to try to avoid and be more cautious for those who have a history of suicidal attempt. Okay. Possible tetragenic risk. So again, I do not see this used in pregnancy. It's not safe for a lot of you in the class who are midwives and interested in women's health and things like that. This is one you're probably not or haven't seen with your pregnant patient. Again, another little mnemonic for those of you who are a little tricycle for tricyclic, but for those who are more visual learners. All right, there's more dosing again. Now, this is like if we're going to treat depression, okay? So again, use this, take it for what it is. This is just usual dosage range, does not mean that you have to start 150 milligrams of imipramine, okay? Or amitriptyline. There has been as low as 10 milligrams used to help people with nerve pain. There has been low as 10 to help people sleep. A lot of times you'll see amitriptyline 25 to 50 milligrams usually used at night to help them rest. Nortriptyline is one of the very few. So elderly is another thing. We don't usually like to prescribe TCAs with elderly, but nortriptyline is oftentimes and has been known more research to be more safe than other TCAs, less likely to have the adverse effects with nortriptyline with elderly. So you may see that, but again, dosing does not mean you have to start at those doses. Doxepin, oftentimes we'll see also lower doses, 25 to 50, used for rest, used for sleep. Imipramine, and I think you're gonna see varying opinions on the beliefs of that, but that can help because of the urinary retention and the drying side effects. People have seen this prescribed with children for bedtime wetting. And so the kiddos may take it at night, and there's that belief that maybe hopefully taking it for a short period of time, being come off of it, that it's retrained them and gotten them in a pattern where they're not going to have the incidence of the bedwetting. However, a child psychiatrist I worked with prior, she had the belief of no, not even wanting to do it. She wanted them to be able to train on their own. So you're going to see varying opinions, but again, it depends on the child and what they've been through and what other things they've tried in the past if you're looking at prescribing. All right, so MAOIs, to come up with a little thing. Again, I told you selegiline I could kind of throw in there, but selegiline actually, so I'll say this, it has less likely to have the risk or the dietary interactions that we're about to discuss in here. And you guys hopefully remember this when back from nursing school or are going through, I don't know if family practice you guys go back through some of the psychiatric drugs, but these are those ones that everybody always tries to avoid with what we're going to say those tyramine containing foods. But selegiline a little less likely to that. But there was a mnemonic always for people to remember: no popular meds. And that was usually remembering those top three: Nardil, Parnate, and Marplan. Those are the three most common MAOIs that you'll see used in practice. If you see them in practice any longer. Here in a second you'll see the slide. How many foods you have to avoid? It can be very difficult. So indications: depression, panic, social phobia, bulimia, PTSD. Again, primarily metabolizing norepinephrine, serotonin, epinephrine, dopamine, and tyramine. So MAOIs actually really hit multiple things. They're really cool in the fact that, hey, they've actually got more action potential than our neuro ones. However, again, as I was just saying, sometimes when you're on that pathway and, hey, we're going to make things better, you kind of bump things along the way. And so, unfortunately, we have more risk of side effects with these medications because they have more action potential. So our adverse effects, again, orthostatic hypotension can happen with these, insomnia where you can't sleep, weight gains possible, edema, sexual dysfunction, several drug interactions. Oh my goodness. And this, like we were just saying, MAOIs, you have to wait when you are going to another antidepressant. You're going to have to wait the 2-week period, and that can be very, very frustrating and also worrisome for knowing those 2 weeks without anything prescribed for those patients. There are different IV antibiotics and things like that that can have interactions also with MAOIs. Tyramine-induced hypertensive crisis. Here we go. So you've got to avoid tyramine-containing foods, okay, because of that risk of hypertensive crisis from the medications. From the food, the combination of taking the medication and the tyramine contained in the food. And this probably, if you remember back from nursing school, was probably that whole, oh no, beer, cheese, and wine. I think that's the three that most everybody remember most. But in reality, it goes beyond that. It's things like, a lot of people don't like sauerkraut, but sauerkraut, alcohol, they're okay, wait, yeah, that's the beer. Cured meats. So for maybe those who like sausage and meats that are more cured and older type pepperonis, things like that, you're going to need to avoid. And so just thinking about every day, like ordering a pizza. You can't have any sausage and certain hams you can't. So, I mean, got to be very, very mindful about that. Can't have pepperoni and sausage on your pizza. Bananas, a lot of, I know that's more of something I always necessarily remember. Avocados, so if we're thinking about you going to a Mexican restaurant, you want to order a thing of guacamole. Okay, pickled foods, figs. I'm pretty sure there's actually raisins is on this list as well. That's back when I taught BSN program. I used to throw in kind of like come up with a diet plan that was specifically appropriate for your patient, and it might be a combination. It might be that there was a chocolate raisin cookie. So being mindful, and for patients trying to remember these things, I didn't include there's forms of yeast also you have to avoid, and chocolate. Oh my goodness, chocolate. And a lot of people like this. So it becomes very, very difficult in teaching patients, and actually you really have to have somebody who is going to be compliant, that you really think could follow in with this, not being able to order hot dogs because of the meat potential there. Really being mindful with dressing, aged cheeses, blue cheese, people like feta cheese, you really, really need to be mindful in what you're eating. So, and there's another little mnemonic to kind of help you guys remember. All right, usual dosing again. So here's about typical adult dosings usually. So you'll have those. Again, I don't mind to say I have not ever prescribed an MAOI. Maybe it's because of just being scared because of all the tyramine containing, but that is something I've always avoided. A psychiatrist I worked closely with for a long time, he had done selegiline, and that is the only one that I've seen, and it was someone he trusted and who'd honestly been through multiple drug trials of anything else, and MAOI was kind of like that last one on the list. Let's hit and let's see what we get. Okay, the Manorex, I had included that and I didn't even put selegiline in this, I apologize, but the Manorex is actually, it's now saying it's less likely to also cause these, so that and selegiline less likely to have the reaction as severe with the tyramine containing foods, but it doesn't mean that it's not going to. All right, other antidepressants. So tetracyclic, I will say this. So many people that I've actually talked to other prescribers and friends of mine who want to classify trazodone or Desiril as a tricyclic. It is not a tricyclic though, okay? It's not a TCA. It is a tetracyclic. It works a little bit differently. It doesn't come with quite the side effects, not quite as drying as your TCAs. A little bit different side effect potentials. But mirtazapine and trazodone, I always call those the sister drugs. They are to me more similar in their action and the way that they are composed. NDRI, or norepinephrine dopamine reuptake inhibitor, right now just bupropion or Wellbutrin, and then the atypical, the vortioxetine or Trintellix. Like I said, it might be Brintilix in your book, but same thing. It's also going to work a little bit differently. So if we go through them, mirtazapine and trazodone used for depression, anxiety, off-label for sleep. Mirtazapine also stimulates their appetite. So we actually used all the time on the Jerry Psych unit. We would do mirtazapine, especially with dementia clients as they forgot to eat or didn't really have an appetite, never losing weight. It's something we can add on. If you have that really depressed person who is starving themselves and not eating from stress, that might be a good option. And they're also having trouble with sleep. So that we dose it, just so you have an idea too, dosing wise, the mirtazapine can be as low as 7.5. We would even sometimes do a half tab at 3.75 milligrams up to 45 milligrams. Again, the lower doses, really what you're getting more is a more histamine type reaction, and so you're really just adjusting and honestly helping with sleep, making a little bit of appetite. The higher the dose of the mirtazapine, the more activating it becomes more of an antidepressant. Same thing for the trazodone. The lower doses are more for sleep, and then again the higher doses really become more of use for depression itself and not just the more histamine type reactions. So both of those again used. We use trazodone all the time in the Jerry Psych unit as well, but both are used for sleep. Mirtazapine just more likely increases the appetite. I don't hear the appetite increase or weight gain with trazodone specifically. Mirtazapine also, if you think about those patients who are going through cancer and chemotherapy, again with the nausea, there's a little bit less GI disturbance, and that can be more settling for those patients as well. Trazodone, too, I mean, like I said, it's good for sleep, and we'll go over side effects here in a minute, and I'll talk about it more what I was going to say. But Wellbutrin, Used for depression, smoking cessation. People might see it as Zyban to help to stop smoking. Seasonal affective disorder, ADHD, cocaine detoxification, and hypoactive sexual disorder. So I want to stop and kind of focus in on well, two things. So cocaine detoxification. If you think about, so cocaine, and we'll learn more with substance, but it is very stimulating to the brain, right? So we are actually hitting similar. Are we taking a drug that's necessarily telling our body to produce more of that chemical? No. But we're taking a drug that is basically helping us to hold on to what we have that we've been losing too quickly. So sometimes we get a little bit of activation and similar effects, since it may be a little bit easier for those to not necessarily resort back to cocaine by having something that's still working similar, but actually being dosed appropriately and that is legal, that we can use. And then the hypoactive sexual desire disorder, unfortunately, those things that we talked about with SNRIs or with SSRIs, is that people may honestly just, when we say sexual disturbances, a lot of times it can be for females, it can be a delay of orgasm or anorgasmia, where you do not orgasm. It could be for our males, again, the erectile issues. It could just be just sexual desire in general, just not have the desire any longer. Or if you're having a lot of delayed ejaculation as well, then this can actually be added to, could be used individually for the depression or added to an antidepressant to help actually reverse those side effects, kind of combat the side effects with the SSRI and SNRI. So that's a really good thing. So you don't necessarily have to leave a working SSRI, SNRI to work out the side effect kinks. And if Wellbutrin doesn't, there's other things we can do. There's things like I mentioned, we're talking about serotonin syndrome. Periactin can sometimes be used in small doses prior to sexual activity. And usually I think I'll have to look it back up, but it was 1 to 2 hours prior. I know that's always hard to plan, but something that can be used to kind of help with that. And so you may have more likely to have that orgasm or not have the ejaculation issues. So, all right, and then Trintellix, the newer one used for depression, anxiety, and Trintellix is marketed out that it is the pill that they say, hey, there are no sexual side effects with this one. Well, great. I mean, that's wonderful. I think there is a very, very few and small percentage that does, but is a lot less likely, they're saying, especially with males. One of the local physicians around here is actually using it more often because then he likes to use it with the males specifically because he's seeing less erectile issues. No weight gain associated in the studies, a very, very small percentage. And so Trintellix is kind of being that choice. I will tell you, for insurance purposes, depending on their plan, sometimes you do have to fail 2 generics. And you guys are already practicing know. It's just to kind of get around the system with insurance. Sometimes it is the 2 generic failed trials, and then you can get the approved for the brand name. All right, so just a little bit more about their action. Mirtazapine, trazodone, again, increasing serotonin and norepinephrine through reuptake. And then the Wellbutrin inhibiting norepinephrine and dopamine. And the Trintellix, specifically inhibitor of serotonin, but also different modulators and different various serotonin receptors. So it's not just one, it's multiple. And I believe when we were hearing the rep coming in for a drug luncheon, it was like 5 different receptors that it's actually hitting, so it provides just a little bit more than the regular SSRI. All right, so adverse effects. Mirtazapine can be a little sedating, obviously, but we can give it for sleep. Can have a little dizziness. I don't usually have that reported, and one good thing about taking medications at bedtime, sometimes you avoid some of the side effects. Can increase your appetite. Weight gain. I don't necessarily see weight gain just by taking it. It's usually because they're eating more or they're snacking, and they need to. Anything, if you're going to use mirtazapine and trazodone for bed, teach patients anywhere from 30 minutes to 2 hours before bedtime. More often, the norm is 30 minutes to 1 hour before bedtime. If they sit there and try to fight it, that is when I've seen more of that night snacking happen. There are some kiddos that sometimes can take it. Those are used for children to help them rest as well and coming down, especially with ADHD kids. And those need to be, sometimes with kids, it is 2 hours before bed. But usually in a half an hour to an hour before bed. Trazodone can cause a headache, again, dry mouth, sedating, can have some nausea, constipation, possible. Vivid dreams. I actually hear this, I'm not going to say all the time, but fairly frequently, that and sometimes they're kind of weird. pleasant dreams, and sometimes if they actually become very nightmares, scary, gory, that's when we may want to look at something different. And I'll just tell you, just as another little clinical tidbit, is that mirtazapine I've actually used, and there's been some benefit with reducing nightmares with mirtazapine. It was very effective for a female client that I had, was in a car accident and lost her friend in the car accident, and continued to replay that same incident, and mirtazapine seemed to really help with her. Again, everybody's different, but have seen some benefit there. Priapism, if you don't know what that is, so if you ever watch those Cialis commercials, erection lasting longer than 4 hours. Now, can I say that I've never seen this in my practice? Yes. Can I say most of any of the psychiatrists I've talked to? No, they've never seen it either. However, you know, sometimes there might have been that one person that had this. And so with my males that I start trazodone, I do go ahead and review over the possibility of the risk. And just as the commercial says, as I tell them, go on to the emergency room if it were to occur. Bupropion or Wellbutrin, again, can cause headache, insomnia, dry mouth, tremor, restlessness, agitation, you know. It is more stimulating. Sometimes, unfortunately, it can be more agitating. We do watch their hypertension, and that's also because of norepinephrine and dopamine. And so we do need to be paying attention to that. Necessarily doesn't mean it's going to shoot it sky high, but we need to be alert, especially if they already have pre-existing blood pressure issues. Now, I've also got seizure on there, but think about it. Bupropion is stimulating. We don't want to overstimulate the brain. So if you have a history of seizures or you carry that diagnosis of epilepsy, that is not, you are not a candidate for Wellbutrin. That is actually one of those things that while we're going through the list and ruling out things and you're thinking, let's try Wellbutrin, you have to ask, do you have any history or currently have any seizures? Okay. Now, where it also was, and that your book necessarily didn't include, but I want to make sure we throw it in there correctly, and I may have it later on here, but it's eating disorders. For those who have eating disorders, specifically if you have bulimia or anorexia, and I'm not talking about those who overeat, but undereat, you know, a lot of times your electrolytes and different things can go out of whack or dehydration, and so you're already more at risk for seizures. And so it's also a contraindication to put Wellbutrin on board with somebody who is bulimic or anemic. Excuse me, not anemic, anorexic, because we don't want to throw them into a seizure. Vilazodone or Vibrad, it is nausea, headache, dry mouth, dizziness, and I realized that Vilazodone, and we were talking about Trintellix, I apologize for that slide there. Trintellix, I'll tell you, is Trintellix one of the worst things, well both, I'll actually say this for both, so both Vibrad and Trintellix, nausea. You guys, like when they're titrating up on their Vibrad, sometimes there's still some samples packs, and they do 10 per week, and they'll do 20. Sometimes you stay on 20, and then you can go up to 40. And then Trintellix is usually starts at 10. They have a 5. Starts usually at 10 for most adults, and you can go to 20. If patients can get through the nausea on either one of those and hang in there, it will eventually go away. But that is sometimes the make or break for patients. They're like, I cannot do this nausea, and they cannot continue that medication. And so just be mindful and alert for that, that they just may not be able to tolerate that. But to also try to hang in there, try to eat with food. Sometimes taking them at night can help to prevent that nausea issue. And a lot of the same actual side effects for Vibrad and Trintellix are very, very similar. So again, more clinical tidbits. We already mentioned, I put in there nightmare suppression. Also, again, used for child for sleep, appetite increase, Wellbutrin. They have actually marketed it with naloxone and remarketed as another drug that they're using for weight loss medication to help people weight loss. They say the naloxone helps the Wellbutrin to last longer and it holds more steady. Helpful also, like we were talked about, for add-ons for sexual side effects. And because there's no serotonergic agents in Wellbutrin, let me say that again, because I literally have been on the floor, even back when I was teaching BSN program, and been on the floor, and a nurse come over and say, oh yeah, Wellbutrin, it's an SSRI. No, Wellbutrin has no serotonergic properties, okay? So because of that, and you'll understand this more as we get to mood disorders, but it's less likely, doesn't mean it's not, okay, less likely to cause mania, and may be an option for you if you need to treat somebody with bipolar disorder who has depression, okay? So it could be less likely to cause mania. I'm not saying 100%. All right, and I think that is the end of our slides. Wow, okay, so that was our lecture on depressive disorders. I see that we're running about an hour and a half. I will try to maintain these more in about an hour, but I just want you guys to get a good bit out of it. Our anxiety presentation will probably a little bit shorter because we've already gone over antidepressants. But please, please, please reach out, put any questions, concerns, comments in the discussion post where this will be linked, and I will try to check that and make sure that I answer. And again, if you need to send a message or Google Hangout or email, I will help out as much as I can. Y'all have a wonderful week. I hope you've learned some things about depression, and we'll see you in the discussions. Have a good one.